the pharmacology of this is really important. Were you guys all able to access your, by the way? Okay. Any questions about this? It might change based on the semester. If it will, I'll send out an announcement and change it on the calendar. So you guys should all have that information. But please email me with any questions anytime. So about 1 in 3 Americans has hypertension, about 29%. Compared to a couple years ago, this is actually down a couple percentages, which is good because I think there's more focus on, eliminating salt from the diet and healthier lifestyle. So that's good. But still, it's about 1/3 of our population has hypertension. Hypertension, as you know, is a major risk factor for heart disease, stroke, congestive heart failure, and renal disease. So those are all things you think of if you go to meet your patient and you hook them up to the blood pressure monitor and you see, 220 is over 120. You're thinking there's other things going on. Depending on what surgery it is, you may or may not decide to cancel the case and get them under control for their safety before you proceed. It costs about $46 billion every year. And this is time lost from work, this is cost of medical visits, all of those things combined. So it's a very costly disease to our country. And then almost 1,000 deaths have hypertension as either the primary or second, like one of the contributing causes. So that's a lot, and that's every single day. And this is according to the CDC, so I believe it. And about 1/3 of Americans have pre-hypertension. So between 1/3 having diagnosed hypertension and 1/3 having pre-hypertension, that's a pretty big deal. Women are about as likely as men to develop it. And more than 1 in 5 people who have hypertension it affects specific target organs, specifically the brain, the heart, the kidneys, as we discussed before. And it accelerates and exacerbates the onset of atherosclerotic changes. So that means these people are more likely to have coronary artery disease, which is also a big deal when you're going to administer anesthesia for them. As you know, just a review of your arterial blood pressure, it has cardiac output multiplied by the peripheral vascular resistance is what gives you your arterial blood pressure. The components of the cardiac output are your heart rate, contractility, and filling pressure. And then the peripheral vascular resistance is your arterial volume. So just to kind of do another review of arterial blood pressure, let's see. Your body has very specific ways of regulating blood pressure to keep it at a safe level. And this is important in understanding pharmacology because if you understand the physiology of how the body works, then you can understand the pharmacology of how the drugs act on it. So you have both rapid acting blood pressure control mechanisms, and then you have some long-term control mechanisms. And those are important. So we'll go through all of them. So your rapidly acting blood pressure control mechanisms are things like your baroreceptor reflex, your chemoreceptor reflex, your atrial reflexes, and your CNS ischemic reflex. We'll go through each one of these. Do you guys have, I'm not sure what your background is as far as the classes that you took. Do you get an anatomy physiology class? Mm-hmm. So you guys, this is pretty much a review for you guys. So to talk about your baroreceptors. Baroreceptors are receptors that act based on pressure, so baro's pressure. So they sense pressure with blood volume, and those can be located in the left atrium, left ventricle, and pulmonary veins. The major baroreceptors that we focus and concentrate on are ones that really sense your arterial blood pressure, and those are found in your carotid sinuses and your aortic arch. So basically what happens is these are stretch receptors. So as your blood pressure is going normally, if it increases, it stretches your blood vessels. That stretch will cause an action potential to go up to the brain and synapse in your brain stem to cause very quick results. In your carotid sinus, these sense between pressures between 60 millimeters of mercury and 180. So they really don't do much. They're kind of firing at their over set rate. But once your arterial pressure goes above 60, then they start firing. The more it goes up, the more firing they're doing. And what that happens is once it synapses in your medulla, it causes a stop of that sympathetic outflow. And it also stimulates your parasympathetic nervous system to cause things like decrease in heart rate, decrease in contractility, and then vasodilation. So that would then lower blood pressure. Now, over time, just like anything in your body, these things start adapting. So if you're chronically living at higher blood pressures, these don't keep firing and lowering your heart rate. We then need medications to do so. Your baroreceptors in your aortic arch start working after 30 millimeters. Volatile agents inhibit the baroreceptor reflex responses. So you won't see if there's a huge increase in your blood pressure when a patient's under anesthesia, you won't see a big drop rate in their heart rate. So those are things that you have to think about because you're going to be giving medications to do that. Okay, so just a little picture of where these things are located. So basically, like I said, they're your carotid baroreceptors are right in the bifurcation between your internal and external carotids, and they're stretch receptors. So as soon as they feel that stretch in your increased blood pressure, they're going to start sending synapses. They go up your cranial nerve 9, which is your glossopharyngeal, so it will send right up there, synapse in the medulla, and come right back down to decreased heart rate. The other ones are in your aortic arch, and those stimulate your vagus nerve. And those are really important, especially in things like carotid surgeries. You'll see this response can be, you know, when somebody's pushing on a carotid or doing like a thyroidectomy or something. If they're pushing on it, you can see a huge rate of cardiac response. And those are because you're stimulating these baroreceptors. Any questions on that? Okay, so we talked about baroreceptors. Next are the chemoreceptors, and chemoreceptors are going to sense changes in your chemistry, right? And basically, they sense when your oxygen level's low or when you have excess carbon dioxide and hydrogen ions. They don't respond strongly until your systolic blood pressure is less than 80. And what they'll do is they'll cause more of a vasodilation. So if your blood pressure drops, they're going to increase your sympathetic output, vasoconstriction to increase blood flow to the area. They're very important in responses to PaO2s less than 60. And these are you have them in your bodies in your aortic arch as well. This picture was just a good picture to show kind of the physiology of how it works. You also have them in your brain, and that kind of goes into when we talk about your CNS ischemic reflux. So all of these contribute. So basically, your carbon dioxide is going to diffuse over the capillary membrane. It's going to bind with water to form carbonic acid, which breaks into bicarbonate and hydrogen ions. Those hydrogen ions stimulate the chemoreceptors and will then elicit the action potential to get the response. Next are atrial reflexes. These are low pressure stretch receptors that evoke vasodilation and decrease your blood pressure in response to atrial stretch. They cause an increase in heart rate because they have a direct effect on your sinoatrial node, and this is known as the Bainbridge reflex. So you can see if you give a big bolus of volume in a healthy heart, that stretch in their atrium of their heart is going to speed up. You'll see like a little bit of a increase in heart rate to kind of increase that cardiac output. It also activates the kidneys, and because this would be dilation of your afferent arterioles, and this would decrease the secretion of antidiuretic hormone. So you would excrete more of them. So this can cause an increase in your heart rate as much as 75%, and the increase in heart rate increases your cardiac output. And this is just kind of a schematic box. Basically what happens is you have an increase in your blood volume, which stretches those atrial volume receptors, which would then increase your atrial natriuretic peptide from the atrial myocyte. So it releases this hormone, and that directly works on your kidneys to increase your GFR, your glomerular filtration rate, and increases sodium and water excretion. It also decreases your antidiuretic hormone or your vasopressin, which increases water excretion, which decreases your extracellular fluid volume and decreases blood volume, which would decrease your blood pressure. Also increases your heart rate, increases your cardiac output, which increases your renal perfusion, which does this whole thing. So it kind of works in a very amazing way, if you ask me, to control these. And these are all, remember, these fast blood pressure control mechanisms. And the last one is this central nervous system ischemic response. This occurs with decreased blood flow to the medullary vasomotor center, and this is when ischemia occurs. So below 60, your PaO2 is 60, or 50, I'm sorry. Results in intense sympathetic nervous system activity. When your MAP falls below 50, then it's really activated, and this is an emergency control system. I'm sure you've heard of Cushing's triad, and that's where this is occurring, where your brain's ischemic for whatever reason, and it will activate this. This can elevate your mean arterial blood pressure to as much as 250 millimeters of mercury for as long as 10 minutes. Yes.
What did you say with the PaO2?
I'm sorry, it's like infant lessons when it's very ischemic. So once you're falling down on that oxyhemoglobin dissociation curve and it's ischemic, I would go with the blood pressure. You won't get tested on these numbers. It's just so you can understand the physiology of how this works. So this is kind of your body's last resort to really ramp up the blood pressure. Yes.
So these receptors, all four of them, they can do both, like increase blood pressure and decrease blood pressure based on what's going on?
Yes. So basically, the big ones like your baroreceptors, you all have a balance between your sympathetic nervous system and your parasympathetic nervous system. So whichever one needs to be is going to elicit the response of the other. So for instance, if your blood pressure is too high, then these receptors are going to stop your sympathetic outflow, and they're going to increase your parasympathetic outflow. Versus two, if your blood pressure is too low, they're also going to sense those, and they're going to stimulate your sympathetic outflow to increase your heart rate, increase blood pressure, and they're going to decrease the parasympathetic. So you think of it as like a teeter-totter, and say, somebody who's larger sits on, then you're going to need more things happening on the other side to balance it. Versus, does that make any sense?
Yeah.
Okay, so we talked about the short-term control mechanisms. And again, these will adapt. So people who have hypertension, these are going to adapt. They're going to have different standards than people who don't. And then you have long-term blood pressure control mechanisms. And just like anything in the body, like if the blood pressure is constantly out of whack, it's going to kind of stay on that track and it shifts everything. So your long-term blood pressure control mechanisms would be your renal body fluid system, your Renin-Angiotensin System, your aldosterone, your sympathetic nervous system stimulation, and your vasopressin system. And this is just a schematic. Everything's kind of tied together between your brainstem, your heart, your kidneys, and your blood vessels, and they're constantly working together. And we'll go through all these different mechanisms so that you can understand what's going on. So your renal body fluid system, this is kind of a primitive system. This is your blood volume increases and your vascular capacitance is not altered. So your arterial blood pressure increases. So the increased pressure pressure causes the kidneys to excrete more volume. So your kidneys are very, very, very important in blood pressure control. This way and through the other systems too, the Renin-Angiotensin System and the vasopressin system. So increases in arterial pressure of only a few millimeters of mercury can double renal output. And these are in healthy people with healthy kidneys. A decrease in arterial pressure causes the kidneys to excrete less sodium and therefore water always follows sodium. So lower T. An expansion of the extracellular volume, plasma volumes, will increase your cardiac output and arterial blood pressure. The next is the Renin-Angiotensin System. Do you guys know this system pretty well? This is one that we go in over excess all the time, but it's very important. So 85% of your resting blood pressure is controlled by renin. Renin we'll go over this. Renin is secreted by the kidneys. It goes to the liver where it's converted to angiotensin 1, which then goes to the lungs, which is converted to angiotensin 2. And then angiotensin 2 constricts blood vessels. It enhances sympathetic nervous system activity, causes sodium and water retention, and aldosterone release. And we'll go through each one of these. So the juxtaglomerular apparatus in your kidneys will secrete renin. And then, like I said, renin turns to converts angiotensinogen in your liver to angiotensin 1. Angiotensin 1 goes to your lungs, where it's converted to angiotensin 2 by angiotensin converting enzyme or ACE. Okay. And then angiotensin 2, like I said, increases sympathetic activity, increases sodium reabsorption, stimulates the secretion of aldosterone from the adrenal cortex, and causes arterial vasoconstriction. Just another one of these little things, just so can you tell I like pictures? Yeah. I'm a very visual person. It helps me, so I apologize. I once when I was in Cincinnati, I took a class and I'm like, she has way too many pictures. Sorry, I'm like a kid. I like pictures. Okay. So if you have a decreased effective circulating volume, so decreased volume, decreased blood pressure, will cause the release of renin from your juxtaglomerular apparatus, which will cause angiotensinogen to be converted into angiotensin 1 to angiotensin 2, which angiotensin 2 will increase your aldosterone release, which increases your distal sodium reabsorption. We'll go into more detail with this. And also angiotensin 2 will increase your proximal sodium reabsorption. So in multiple places this is going to work to increase your sodium reabsorption from your kidneys. Water follows sodium, so that will increase your blood volume and increase your blood pressure. Angiotensin 2 is also a very potent vasoconstrictor. So along with kind of increasing your blood volume, it's also going to act on those blood vessels to cause vasoconstriction. It increases your ADH release, which causes water retention. ADH is antidiuretic hormone, so it's not that sodium, it causes water retention. And it also increases your thirst. So you think of like one little thing doing so many things. That's why it's so important, and it controls 85% of our resting blood pressure. Okay, aldosterone is a mineral corticoid secreted by the adrenal cortex. It increases the reabsorption of sodium and the secretion of potassium by the principal cells in the clotted. You will hear principal cells a lot, so that's just something that I think it's a good thing for your boards and all that to know. Sodium is reabsorbed, water follows, so that increases your extracellular fluid volume. Sorry for being so redundant. It's secreted in response to angiotensin 2 and high serum potassium. So those are the two things that will cause aldosterone to be secreted from your adrenal cortex. Just another picture of how it's going to increase your sodium reabsorption, decrease potassium, and water will follow your sodium. So we talked about your renal system, we talked about the Renin-Angiotensin System. Now we're going to talk about the sympathetic nervous system stimulation. Oh, and we talked about aldosterone. So your sympathetic nervous system will increase your cardiac output. When stimulated, will increase your total peripheral resistance, which is the other side of the contributing factors to arterial blood pressure, and will cause your renal retention of sodium and water. And this is just, I can explain this a little better. So all of these, again, are working together. So if you like, this seems like it's kind of a component of the renin-angiotensin, they all are. They're all kind of working simultaneously to control your blood pressure. So your vasopressin is going to act, baroreceptors are going to stimulate your sympathetic nervous system. What these are going to do is they're going to, and we'll go into this in the next lecture a little more too, they're going to send out sympathetic efferents, which are going to act on your adrenal gland to secrete renin. It's going to act directly on your blood vessels to cause vasoconstriction. It's going to act on your sinoatrial node to increase your heart rate and blood pressure, or increase your heart rate, which will increase your cardiac output, which will increase your blood pressure. Does that make sense to everyone? So they're all kind of working simultaneously. And then lastly, is your vasopressin or your antidiuretic hormone, which we're going to talk a little bit, but we're going to hit on a little more. It's primarily regulated by an increase in plasma osmolality. And as you know, osmolality, all that is a measure of the amount of particles that are dissolved in a unit of water. So it's basically sensing how your electrolytes, are in your blood body. So if you're pretty hemodiluted, your osmolality is going to be lower. But if you're hemoconcentrated, does that make sense to everybody? Your osmolality is going to increase, and that's what's going to stimulate the vasopressin system. So changes in blood volume and arterial blood pressure can also stimulate this, and the secretion is exponential. And this just means that small decreases in your blood volume can cause large increases in your vasopressin and your antidiuretic hormone. Does anybody have any neuro experience, like neuro ICU experience? This is like something that you see like in people who have diabetes insipidus, where they're high osmolality and they're dry because they're getting rid of it because they have a problem with too much or too little antidiuretic hormone. So their kidneys are just excreting all this water. They're maintaining their sodium so it's high and dry GI. So if you have an experience. So you have a water deficit, so you have increased extracellular osmolality, which increases your ADH secretion, which increases your plasma ADH, and increases the water permeability in your distal tubules, in your kidneys, in your collecting ducts, which increase your water reabsorption and increase, and then that will eventually lead to increased water excretion over time to kind of balance it. So vasopressin has two functions. The primary is the antidiuretic hormone. The secondary property of vasopressin, which is ADH. ADH is just another name for vasopressin. It stimulates these V1 receptors on the smooth muscle of your vasculature, and this causes vasoconstriction. So not only does it act on the kidneys to retain water, but it also causes direct vasoconstriction of your vasculature. Okay, so there are some people who, under anesthesia, you will give vasopressin to. These are people that are usually on ACE inhibitors. You don't need to know this for the test, but just for your knowledge. Like, there are some people who are on ACE inhibitors, and you're giving them phenylephrine or ephedrine, and their blood pressure is never going up. And so then you kind of think in the background, vasopressin, because it acts kind of to offset what the ACE inhibitor is doing, and it also has this direct vasoconstricting property to it. Okay, so now we talked about arterial blood pressure regulation. Does anybody have any questions about it? We talked about the short term, the very fast regulating, and then we talked about long-term control. A little bit about hypertension, just so you know. Obviously, you guys know blood pressures, and now these are the American Heart's classifications. And I feel like they're getting more strict, like the more years that pass, the hypertension is coming from 130 now, or I guess, yeah, stage 1 is 130 to 139, and that used to not even be to 140. So they're kind of getting a more, they want it to get even more controlled than what it is. Your MAP is the most important determinant of tissue blood flow. The risk of cardiovascular disease doubles with each increment of 20 over 10, so 20 diastolic over 10, 20 systolic over 10 diastolic millimeters of mercury above 115 or 75. So that's crazy. So you have somebody with 155 over 95, and their risk of cardiovascular disease is 4 times as much as it would be at 115 over 75. So it's a big deal. In order to classify somebody as hypertension for the American Heart Association, you have to have 2 measurements 5 minutes apart, and they both have to be high. If you hear the term pre-hypertension, it's not a disease classification. It's just meant to like identify people that are at risk of developing hypertension. So if somebody says I'm pre-hypertensive, you don't have to make them an ASA2 just on them. Okay, so hypertension falls into 2 categories. There's primary or essential hypertension, which is no identifiable cause, and the diagnosis is determined by exclusion. Excessive weight gain and obesity may account for as much as 65 to 75% of the risk of primary hypertension. So they don't really know why, but obesity is a really big contributing factor, and we'll go into this in a couple of slides. There's some speculation that deposits of collagen and some other proteinases within the intima of the arteries just kind of accumulate over time, and this occurs with aging, and that can also contribute to this essential or primary hypertension. The remedial or secondary hypertension has an identifiable and potentially curable cause. Things are like pheochromocytoma. Do you guys know what that is? Mm-hmm. Okay. If you have one of those, if you see one on the schedule or you can do stage 4, do it because it's a big deal. You don't see them often, but it's amazing how much those can contribute to your blood pressure. And then the removal of the tumor will cause it's like instantaneous decrease in blood pressure. They're pretty cool. Coarctation of the aorta, and that's pretty much because it's constantly stimulating those baroreceptors over time, so that can cause the secondary or remedial hypertension. You can have renal artery stenosis, and that's because your kidneys are constantly sensing that they're not getting enough blood flow. So what are they going to do? They're going to stimulate that Renin-Angiotensin System and do all this to try to maintain blood flow, and that will eventually increase your blood pressure. My father-in-law got this. He all of a sudden, healthy guy, felt horrible, went to the ER, had a blood pressure of, again, 220s over 120, something insane. And this is somebody who runs every single day, has been active, and they did all this, and he's like, and they kept trying to tell him, well, you have hypertension. He's like, no, I get these physicals all the time. I have no problems with blood pressure ever. And they did a angiogram or something, and they found that he had renal artery stenosis, and all that they had to do was go up and put a stent in for a little bit, and it cured itself. He's on no medication. So that's how real this stuff can be and how greatly it can affect your blood pressure. Primary renal disease can do this as well, such as like glomerulonephritis or polynephritis, sorry. And then primary aldosteronism, which is Crohn's disease, and hyperadrenocorticism, which is Cushing's disease. So, and these are just things that if you hear these when you're doing your pre-op assessment, you can just keep in the back of your mind that they might be used to a higher blood pressure.
Did you say Crohn's disease?
Yeah, C-O-N-A, Crohn's disease. Yeah. So we talked about how obesity can contribute to as much as 65 to 75%. And the reason is with obesity, your cardiac output is increased. So there's additional blood flow that's required for all the extra adipose tissue. Blood flow to the heart, kidneys, GI tract, and skeletal muscles increase. And as hypertension is sustained for many months and years, their total peripheral vascular resistance may increase. They also have increased sympathetic nervous system activity. And this isn't fully understood, but I don't know if you've ever heard of the hormone leptin. Leptin has kind of been studied a lot to see if it's something that people who are prone to obesity have more, like something genetically. But what they have found is that this leptin hormone, it's released from fat cells, and it may have direct stimulatory effects on your hypothalamus, which can cause excitatory changes in your sympathetic nervous system. Also, with obesity, angiotensin and aldosterone levels are increased. So that goes back to all those things. Those are increased. You're going to have an increase in all those things, increase in your blood pressure. It may be from increased sympathetic nerve stimulation, which increases your renin release. Also, with essential hypertension, you can have renal pressure natriuresis is impaired. And this happens over time, and this is where your kidneys won't excrete adequate amounts of sodium and water unless the atrial pressure is high or unless the kidney function is improved. So over time, those kidneys are going to, with increased blood pressure, they're going to, I'm trying to think of a good way to say this, they can kind of get burnt out, for lack of a better word. So their ability to excrete sodium and water to lower blood pressure will kind of get exhausted, and this will eventually impair your kidneys. It can also lead to, and this is why people with hypertension end up having kidney problems if it's not controlled for long periods of time. They have chronic reduction of antihypertensive therapies will not cause marked sodium and water retention by the kidneys. So they actually improve kidney natriuresis. So that's why it's important to get people under control, because not only is it going to help their blood pressure, but it's also going to improve their kidney function. Okay. So does anybody have any questions on blood pressure? We'll go for a little bit longer than that's cool with you guys. So these are the different types of drug therapies that are used to treat hypertension. And the ones in black, you'll see the slide again and again. We'll just keep showing them and then which ones we're on. Okay. So the first would be the ways we could reduce blood pressure would be to reduce blood volume, and those would be your diuretics. We can decrease your sympathetic tone, which are sympatholytics, which are beta blockers, alpha blockers, combined the alpha and beta blockers, and then your alpha 2 agonists. And we will discuss that second with our second lecture. We have vascular smooth muscle relaxers, which can be direct. They can be organic nitrates and potassium channel activators. Those are all subtypes of those. Calcium channel blockade, which Dr. Shores will be lecturing on in 2 weeks. So that's something else we won't go over today. And then reduction in angiotensin concentration. Those are ACE inhibitors, angiotensin receptor blockers, or ARBs is another acronym for those. And then ganglionic blockade and inhibition of your neurotransmitter release. So basically for your reduction in blood volume, diuretics are typically first choice when somebody is just developing hypertension. Thiazides have often been your first line treatment, so you'll see a lot of patients on hydrochlorothiazide. That's like the main one. It causes an increase in your sodium excretion, and therefore sodium and water follow sodium. It decreases your blood volume and decreases your blood pressure. It's inexpensive and it has infrequent dosing, so they can take one pill a day, so it's easier for people to be compliant with. But with that, because they also lose potassium, they need to have their potassium levels monitored and then possibly take supplements. So sometimes this is used as a single therapy. Sometimes they start adding things like calcium channel blockers or ACE inhibitors as well. So antihypertensive drug therapy should always be continued without interruption preoperatively, except for possibly ACE inhibitors. There's a lot of question whether ACE inhibitors should be continued throughout the process, just because you will see anybody on an ACE inhibitor, they will have a big drop in their blood pressure after reduction of anesthesia. And sometimes, like I've said before, those people are kind of resistant to giving phenylephrine, giving ephedrine, and you'll have to think of things like vasopressin, or some places put on a phenylephrine infusion just to kind of compensate for that. So there's some speculation that things like, how patients are like, oh, well, I didn't take my medication, especially beta blockers, are really, really important that they continue perioperatively. That's one of the shift initiatives too that you'll be seeing some of the places. Some places the nurses will monitor, like when they take their beta blockers. Some places the anesthesia monitors it, and they have to take it within 24 hours. So if somebody's on a beta blocker, and I'm just telling you this for your knowledge, I'm not going to test it on, but if somebody's taking a beta blocker normally, and say that morning they're like, oh, I didn't take my morning dose, or I didn't take last night because I was supposed to be NPO, then you're going to want to give it to them, because you can see a huge hypertensive reaction. So this is another picture. Hypertensive. Then they're going to add another one in, so they kind of find the perfect mixture, like being a bartender, perfect mixture of medications for them, for their disease. So diuretics, like we said, their goal is to reduce fluid volume, blood volume, by inhibiting electrolyte transport in the renal tubules. The different types are diuretics, Thiazide Diuretics, and then potassium sparing. We'll go into each of these. These are less commonly used than they are in the past, but take people on a lot. Not so much the loop diuretics like the Lasix, but you'll see a lot on hypochlorothiazide, like I said before. Loop diuretics are your furosemide release. Ethacrynic acid, which is edequine, and bumetanide, which is butyrate. So their mechanism of action is going to inhibit the co-transport of sodium, potassium, and chloride in the medullary portions of the ascending limb of your liver. Don't worry, there'll be a picture today. They inhibit the reabsorption of as much as 25% of your glomerular filtrate. So they have a huge responsibility for reabsorbing things. So everything kind of goes into your kidneys. And the way I think of kidneys is anything that goes in is going to be excreted out until your body reabsorbs everything. So your kidneys, all they're doing is pulling back in your body. So if you inhibit something that's supposed to be pulling back sodium, pulling back potassium, and it's going to be excreted in the kidneys. The pharmacokinetics, absorption, and for these, this is more for your knowledge to have. I don't like testing you on nitty-gritty details of things like, oh, well, how is edequine or acid given? That's stuff you're going to know. You're going to know which ones you give IV and stuff, and which ones you, as anesthesia providers, are going to do. So don't fixate too much on this stuff for memorizing, just let's get your information. So that's given PO. Your Lasix is one that you can give PO or, for us, for IV. The distribution is highly protein bound. So people who have renal disease or who have lower protein bound, you just think that they might require less drug because it won't be as much bound to the proteins. It will be more dependent on the receptors. It's renally secreted. The renal secretion of the drug is high, and the duration of action is less than 4 hours. And it can induce hypokalemic metabolic acidosis. So in your, this one first, this is your next slide, but just so you can kind of see. So in your thick portion of your ascending leukokinase, these are where your weak diuretics are going to act. And they're going to block that sodium-potassium pump. So basically, everything that's coming through this kidney is going to be excreted into urine unless it's reabsorbed by these cells to pull it back in. That's going to be reabsorbed into your vasculature. So if you stop this, then all of the fluid's going to come to be excreted. Does that make sense? And those little cells there are responsible, or those little pumps are responsible for about 25% of the reabsorption of sodium and potassium. That's why they're so effective. So they kind of go back. They just block that sodium-potassium pump, and if it's blocking that pump, then that's not going to pull the sodium in, and water always follows sodium. So the sodium is going to stay in the filtrate to be excreted by the kidneys, and water is going to stay there. So side effects, obviously when you're messing with electrolyte pumps, you can have some electrolyte imbalances. You can get loss of potassium and chloride, so you can have hypokalemic, hyponatremic, hypomagnesic metabolic acidosis. And the reason is if you're getting rid of, this is just kind of a basic explanation, if you're getting rid of, your body is always going to want to establish electron neutrality, which means you want as many positive ions as you want negative ions. And the way that your kidneys are really good at doing that is it thinks, okay, anything that we're getting rid of that's positive, well, we can keep hydrogen ions because those are positive too. So if you keep more hydrogen ions because you're excreting potassium ions and sodium ions and other positively charged ions, then you are going to have increase in your hydrogen, which is an increase in acid. It's going to make you acidotic. Does that make sense? Mm-hmm. And you can get acute tolerance, and this is because you're getting rid of so much, your body is going to sense, okay, wait, our blood volume has decreased. So what are your kidneys going to do? They're going to secrete renin. And renin's going to, turn into angiotensin 1 and angiotensin 2, and then stimulate antidiuretic hormones. So it's going to do, and aldosterone. So it's going to try to fix itself because it doesn't realize this is your purpose in doing it. So the treatment for this acute tolerance would be repletion of your extracellular volume. Side effects or drug interactions, this can increase DIG toxicity stores, which can make you more from aminoglycosides and supplements, risk of deafness. I've never seen it personally, but it's there, and it can be transient or it can be permanent. So just think if you're pushing license like crazy. It happens more too in the presence of other ototoxic drugs. Any questions on the diuretics? Do you guys want a break? Sure. Or you want to keep going? 5 minutes or do you want more?
No, like
5 minutes? Okay. The main one you'll see is hydrochlorothiazide. And their mechanism of action are by inhibiting the reabsorption of sodium and chloride ions. This increases the excretion of potassium. This happens in your cortical ascending dependent the most, your proximal renal tubules a little, and your distal tubules a little. Their duration of action is about 12 hours. Here again, they're going to block that pump, which is going to block the reabsorption of sodium, which is going to cause water to not be reabsorbed, which is going to cause it to be excreted in the urine. Effects are hypokalemic, hypochloremic metabolic alkalosis, which, let me look at that because that doesn't make any sense. So that might be, I might have miswritten that one. And I will send an announcement to you guys. It can cause cardiac dysrhythmias, mainly because you have low potassium. can cause skeletal muscle weakness, GI illness, nephropathy, and increased likelihood of developing toxicity and potentiation of the neuromuscular blockage. Side effects will cause concentration because you're getting rid of so much water, so you're getting concentrated. Your extracellular fluid volume is depleted. You can have hyperglycemia, and this mechanism is really unknown, but it may be reflected drug-induced inhibition of your insulin release from the pancreas and blockade of your peripheral glucose use. So I don't really know why that happens, but it is a side effect of thiazide diuretics. You can have hyperuricemia, which may exacerbate gouty arthritis if people complain of that, and you can have the nephropapular rash. Next, we'll talk about your potassium-sparing diuretics, your trimeterine, your amiloride, and their mechanism of action is they act in the distal tubules independent of aldosterone, and they increase the excretion of sodium chloride and bicarb ions. And because they're not acting on the potassium pumps, it's more the sodium chloride and bicarb, you have that potassium sparing effect. So your potassium will still be reabsorbed, so you don't have that hyperkalemia. Spironolactone or aldactone is another name for it. It's actually an antagonist of your aldosterone in your distal renal tubule, so that acts a little differently than the other two. And these are, this is just, do you guys have this one? Mm-hmm. Okay. If there's not, just stop me and I'll write them down. I'll give them to you. So basically, your other two are going to stop this sodium chloride bicarb pump, and your potassium is still going to be reabsorbed. Your other ones are going to block, it's an actual antagonist of your aldosterone receptor. Does that make sense? All right, so half-time of trimeterine is 3 to 5 hours, and amiloride is 18 hours, and this can be altered in patients with renal disease. The side effects obviously would be hyperkalemia. Okay, so we talked about all the agents that reduce blood volume. The decrease in sympathetic tone or sympatholytics, we'll touch on just a tiny bit, but we'll talk about those in a lot more detail. Sure. And these interfere with the sympathetic nervous system function by decreasing your venous tone, so causing vasodilation, your heart rate, your contractility, cardiac output, and then total peripheral resistance. And if you remember, the heart rate, contractility, cardiac output are all factors along with the peripheral vascular resistance that are going to affect your arterial blood pressure. Your types would be your beta blockers, your alpha receptor antagonists, your alpha 2 agonists, and then also your combined alpha and beta blocker. And that's lectured separately. So next we're going to talk about your vascular smooth muscle relaxers. And these are direct acting agents. These are organic nitrates and potassium channel activators. So vasodilators obviously are medications that dilate blood vessels by acting directly on the smooth muscle in your vasculature through non-autonomic mechanisms. So it's not that they're causing vasodilation because they're blocking your sympathetic nervous system activity. They're actually directly acting on your vessels to cause vasodilation. Homeostatic responses may be marked and include salt retention and tachycardia. And this is, again, your body's way. It doesn't realize it's getting a drug to do this, so it's trying to maintain it all on its own. Both nitroglycerin and sodium nitric oxide are nitric oxide donors and cause smooth muscle relaxation via cyclic GMP. So we go into this. These work by the generation of nitric oxide that augments your cyclic GMP in your vascular smooth muscle in your arteries and veins, and that causes vasodilation. This seems to be falling out of favor with other drugs available, but you will see it and you will use it. So nitric oxide, why this is important. So under normal conditions, your blood vessels, nitric oxide is continually being produced, and we'll go over what it does, but that in turn causes vasodilation. It's being produced by your CNOS, which is, I don't have this picture, but I think it's in another one. These are both calcium dependent, okay? So you need calcium for the production of nitric oxide. So it's a physiological messenger that endothelial cells release onto adjacent smooth muscle cells. And this nitric oxide will cause vasodilation. We'll go into that. Nitric oxide activates guanylate cyclase, which increases your cyclic GMP, which causes vasodilation. So basically what happens is you have blood flowing, and in the presence of calcium, it causes L-arginine, which is just I'm forgetting the words, but
amino acid.
Amino acid, that's what it is. Thank you. In the presence of the NOS to cause nitric oxide. Nitric oxide then diffuses out, and it acts with guanylate cyclase to form cyclic GMP. Cyclic GMP will cause the inhibition of calcium to act, so it causes vasodilation. So you'll have more calcium being stored in your sarcoplasmic reticulum, and it will be less produced. So you need calcium, it kind of doesn't make sense. You need calcium to form nitric oxide, but what nitric oxide does by the cyclic GMP is it prevents the calcium to help with that muscle contraction. And that happens on the musculature of your smooth muscles and your blood vessels. Does that make any sense? This is synthesized from the amino acid L-arginine. See, there's a amino acid. In your endothelial cells by a family of calcium-activated enzymes. This is the NOS, the nitric oxide synthase. It regulates your systemic vascular resistance and peripheral vascular resistance under baseline conditions. So it's a major factor in autoregulation. Modulates inflammation, is also involved in the immunologic function. This is why if something elicits inflammation or histamine release, that you have that marked vasodilation, because it will really start being produced with things like histamine, bradykinin, all the things that are kind of in your immunologic reactions. It has a negative inotrope and chronotrope effect. So that means lower your heart rate and lower contractility. Endothelial cells will increase the production of nitric oxide in response to decreased oxygenation. And that makes sense, right? If there's decreased oxygen, they're going to try to vasodilate to bring more blood flow there. Arteries generate more nitric oxide than veins. This may contribute to bronchodilation, and you'll see this because you can actually have patients who are on inhaled nitric oxide, and that actually works on the smooth muscles in your ventilated segment of your lungs. They also can inhibit platelet activation and aggregation and adhesion. This activates the platelet guanylate cyclase and decreases the intracellular calcium there. So I think that it can also inhibit platelet activation, so there could be some increased bleeding. Released in response to stimulation of an NMDA glutamate receptor, and that's because endogenous nitric oxide is a neurotransmitter in the brain. So inhaled nitric oxide produces selective pulmonary vasodilation, so it's not going to have marked hypotension in patients who are getting it. It's used to treat diseases associated with pulmonary hypertension. So typically you will not see this so much in patients who are getting anesthesia, because usually they would probably be too sick if they had such severe pulmonary hypertension. But they can get toxicity from inhaled nitric oxide, and this is, there can be modest hemoglobin levels and life-threatening rebound hypoxemia, and pulmonary hypertension can occur after discontinuation. It's oxidized to nitrogen dioxide and that's a known pulmonary depressant. Okay, so basically, vasodilators that you're going to see, there's going to be direct and your organic nitrates. Your direct is basically your nitric oxide, or you might see it as SNP, sodium nitric oxide, or nitrite is another name of it. So basically, the chemistry of it is it has a ferrous ion, it has an iron ion in the middle, and then it has 5 cyanide molecules. So you have, you see 1, 2, 3, 4, 5, and then you have this nitric oxide, right? And what happens is that once it's in the blood and it activates, or it reacts with your red blood cells, or the hemoglobin in your red blood cells, the iron will go to the hemoglobin and act on those. And so what it does is it releases those 5 cyanide molecules, and it also releases that nitric oxide, and that's why it's a direct nitric oxide donor. So basically what happens is it goes in the blood and this reacts with the hemoglobin. All of these are all released. So this is what's going to act in your body to give you the effects that you want. It's going to cause vasodilating, but you have all this other stuff still in your body that can cause some side effects. Cyanide is reduced to thiocyanate in the liver, and it's excreted in the urine. That's an important thing. So the mechanism of action interacts with oxyhemoglobin, and it dissociates immediately. Like we said, that iron is going to act with the hemoglobin. Forms methemoglobin, and it releases the cyanide and the nitric oxide. The nitric oxide activates the guanylate cyclase just in that thing, just as your normal nitric oxide in your body would do. So it's going to activate the guanylate cyclase, increase cyclic GMP, which is going to inhibit calcium entry into the smooth muscle, and it's also going to increase the reuptake into the endoplasmic reticulum. The dose is 0.3 to 10 mics per kilo per minute, and the max dose you don't want for longer than 10 minutes, and we'll go into why. So once this calcium is inhibited from the smooth muscle, and once it's taken up into the endoplasmic reticulum more, it's not there to cause muscle contraction, and if it's not causing muscle contraction, then you have vasodilation. Makes sense? So nitric oxide is a direct acting, it's not selective. So it acts on both the arteries and the veins the same. It lacks significant effect on non-vascular smooth muscle or cardiac muscle. So that's a good thing. So it's not acting on your skeletal muscle to cause a relaxation or anything. Its uses are for hypertensive crisis, CHF, controlled hypotension during surgery. Can also be done for neuroanesthesia. We would give nitrite a lot. You have a baroreceptor mediated response, so you're going to have tachycardia and increased contractility. Why? Because those baroreceptors in your carotid sinus and your aortic arch are going to sense a lower blood pressure, so they're not going to be stretched. They're going to kind of go back in, and what that's going to do, it's going to increase your sympathetic nervous system output from your brain center, from your medulla, and that's going to cause tachycardia, which is going to try to increase tachycardia, increase contractility, which is going to try to increase your cardiac output to increase your blood pressure, just to try to compensate. You can have intracoronary steel, and that can cause ischemia, and that's because the coronaries that are sick aren't able to dilate. Okay, so if you have other vessels that aren't sick, normal vessels are going to dilate, and your coronaries will dilate. So because they're dilating, they're stealing blood flow from the sick ones that can't dilate. So these sick ones that really need more oxygen and more blood flow to them aren't going to be able to. So it's called intracoronary steal. Yes.
Do you see that it's like transient reflex tachycardia, or do you, in your experience, does it
when
last?
you start, it all depends. Like if you start at a higher dose, like you're really trying to, then you're going to see a faster tachycardia. But if you start it kind of slow, you might see a little bit, and then it will probably get used to it. Remember,
Okay.
Those baroreceptors are short term, so they don't act for long term. After about 10 to 15 minutes, they kind of get used to things, so it's not going to be. So if you kind of start slow, you don't see a marked increase in tachycardia. tachycardia? That's a good question. It can cause increased cerebral blood flow and volume, and this is used in caution in patients with increased ICP or carotid artery stenosis. But you do use it in some neuro cases because it does increase cerebral blood flow, so that's a good thing in some cases. It can attenuate the hypoxic pulmonary vasoconstriction, which would decrease PaO2. You can increase PEEP to kind of increase that PaO2 to kind of combat that. It also may decrease platelet aggregation, so that can increase your bleeding time. So they might be more prone to bleed or take a little longer to clot. Some of the adverse effects, because it causes vasodilation on both your arteries and your veins, it's going to decrease your preload, your afterload, and your cardiac. And that's just because you're not getting as much of the heart to pump out. It can compromise ischemic myocardium and coronary artery disease, and we already talked about that. And that's because people who have coronary artery disease have sick coronaries. So they're not able to dilate, but the other ones are going to be able to dilate, which shunts blood away from the sick area and the sick coronaries. You can have a hyperdynamic response, which we kind of talked about, and that's because that increased sympathetic tone from the baroreceptors. It will also, in turn, cause that increase in renin release, which is going to also try to kind of compensate for what the nitric oxide is doing. You can have rebound hypertension. You can have platelet dysfunction, arterial hypoxemia in patients with COPD, and cyanide toxicity. We'll talk about cyanide toxicity too, because that's kind of a big one that you'll hear about and always keep in the back of your head on the nitric oxide. So the pharmacokinetics, the onset of the hypertensive effect are less than 2 minutes. The duration, it stops within about 1 to 10 minutes of discontinuation. So the metabolism, the 5 cyanide ions, one reacts, or one of the iron reacts to form net hemoglobin, or what actually, I'm sorry. Your iron does react with hemoglobin and it causes a net hemoglobin. One of your cyanide ions will react with net hemoglobin to cause cyano net hemoglobin. And the remaining 4 ions, your remaining 4 cyanide ions, will decompose to prussic acid in the presence of sulfur donor. And that's important because you'll think if you have a cyanide toxicity, you need something to donate a sulfur because you want it to bind with the cyanide to decompose to prussic acid. And then it's converted to the thiocyanate. The half-life of the parent drug is less than 10 minutes. Thiocyanate is 2.7 to 7 days, and its elimination of thiocyanate is renal. Okay, so it's converted to this thiocyanate by the liver and by the kidneys, and it uses this rhodinase enzyme, and that's on another slide, so you'll have that. Does that make sense to everybody?
Yeah. Can you repeat it one more time? You said there are remaining 4 ions.
Okay, so they're going to break down with a sulfur, anything that donates sulfur, and it's going to decompose to prussic acid, and that's converted to thiocyanate. Sorry, and that thiocyanate. So the prussic acid is going to use these rhodinase enzymes in the liver and kidneys to form this thiocyanate. Thiocyanate doesn't do anything in the body, it's just going to take a little while to be excreted. Does that make sense? Mm-hmm. If you don't have these sulfur ions or sulfur donors and it can't all convert to the thiocyanate, then you can have cyanide toxicity. So cyanide toxicity is more likely when your infusion is greater than 2 mics per kilo per minute for 10 minutes. And sorry, that should be may accumulate faster than the ability of the rhodinase enzyme to detoxify it. So there's that enzyme that's in the liver and the kidneys that's used to take the prussic acid that's formed from the sulfur donor and make it into this thiazide. Increased cyanide concentrations may precipitate tissue anoxia, anaerobic metabolism, and lactic acidosis. So it's not a good thing. You don't want it. I'm sure you guys have heard of cyanide poison. You don't want to do that to our patients. Things that you would see mental status changes. They may have a seizure. They may end up going into a coma. Cardiovascular, they have tachyphylaxis. And this is, the tachyphylaxis occurs from cyanide-induced increase in their cardiac output. So what you really want to think is if somebody is on nitric oxide, if they are resistant to getting more, decreasing their blood pressure, even though you're increasing their rate or increasing their dose, you want to think, okay, they're probably getting tachyphylactic. You don't want to give them any more. It's probably a cyanide toxicity. So that's something that you want to think. Anybody who is resistant to the vasodilating effects, you're lowering their blood pressure of their nitric oxide, you think cyanide toxicity. They can have metabolic acidosis in an increasing base deficit, and their cyanide concentrations would be greater than 40 micromoles. I don't know if anybody's ever thought like, hey, let me send this blood down to lab to check their cyanide concentration. I think they would start treating it first and to wait for that, but it's in the book, so that's good to know. Oh, and it may take hours for the lab to process cyanide levels. So yeah, you don't want to wait for cyanide. Okay, so what you want to do is you would wean the nitric oxide. You don't want to just turn it off abruptly because you're going to have a rebound hypertension, and that can be pretty drastic. So you want to slowly wean it down. You want to put them on 100% FiO2, even if they have a normal saturation. You want to support their ventilation as needed. You can get sodium bicarb to correct their metabolic acidosis. And you can give sodium thiosulfate because that will act as a sulfur donor, because you need those sulfur donors to bind to the cyanide to form that prussic acid, which is then going to be metabolized by your liver and kidneys to thiocyanate. If it's severe, you can give sodium nitrate, 5 milligrams per kilo IV push over 4 to 5 minutes, and this will convert the hemoglobin to methemoglobin, which will act as an antidote by converting the cyanide to cyanomethemoglobin. Because remember, one of those molecules does that, and this is just kind of giving them more of an opportunity to do that. Your first line of treatment would be the sodium thiosulfate. You can also give hydroxychloroquine, which is vitamin B12A, and it binds to cyanide to form cobalamin. Sorry. And this does 25 milligrams per hour. You're not going to test it. May produce a reddish discoloration of the skin and mucous membranes. And you can give administration of animal nitrate by inhalation or anesthesia. This is in text. It's good to know in the back of your brain. This is not something that in my 10 years since I graduated, 12 or 13 since I've been in school, that I've ever done. So. Any questions on nitric oxide? Yes.
Well, not on nitric
Yes.
oxide, but speaking of books, are you using Bullet for everything? Or?
I was told that that was a book you have. Is that true? Okay, then I will use that. Yes. I have that one too. I like Stolting Pharmacology and Physiology.
Okay, that's what I wanted to know.
It's a good book if you wanted another one just to reference. It's kind of a backup for filler. Anesthesia is a good one. But you're not going to be tested on anything we haven't talked about that's not in your book. Okay, this book.
Okay, so we'll be tested on things from the book and from your PowerPoint.
Yes.
So just kind of to guide studying as well, just a quick
Yes.
question. Should we base on the topic from the PowerPoint to guide our readings, or should we just read the entire chapter?
I think it's always helpful to read.
Okay, just read the entire chapter.
Yeah.
Okay. I think that we should focus on the
It's a lot of
topic.
reading,
Yeah,
I understand.
Okay.
I don't think that it's fair to test on details that you don't need to know. I plan to, by next week, have some study guides that should help guide you.
Sweet.
Thank you.
Perfect.
Just a note
Yes,
on,
yes,
on
yes.
what he was saying, like, because they do go over some drugs in here that we just don't ever give anymore. And so that's why I'm like trying to skip over those, but that's okay. I'm just
I
making
think
sure.
that if there's drugs that are not in favor or that we don't use anymore, it's not something you're tested on for boards. And so I think, I mean, some things are good to know. I don't think it ever hurts to kind of read and have it in the back of your mind, because you never know when you're going to need the information. But as far as testing, I'm not here to trick you. I know it's a lot of information and it's a lot of content. And so what I'm hoping is that you understand the pharmacology. Really, I want you to understand physiology so you can understand pharmacology.
That's what it seems like.
Is
Seems
that fair?
It seems like she's a big fan of the underlying patho and physiology.
All right, so diazoxide hyperstat is another name of this. This is another direct-acting vasodilator useful in hypertensive emergencies in patients with glomerular nephritis. Has a greater effect on arterial resistance than venous. Remember, we said nitrite acts equally on both. It's chemically related to thiazide diuretics. It can increase cardiac output and heart rate. And it's not recommended for blood pressure control and dissecting aortic aneurysm. That was in the book. I don't know that you'd be wanting to lower blood pressure, but uses: malignant hypertension, encephalopathy, eclampsia, uterine relaxation, and to treat hypoglycemia from insulin secreting tumor. And this is because it has alpha agonist-like inhibition of insulin release. The adverse effects, it's not titratable, and it has a duration of 4 to 12 hours. So if you can't titrate it, and you give it, it's going to last a long time. So that's not really something that we want, especially when you're administering anesthesia. You can have reflex tachycardia for the same reason that nitrite would have it, because you're lowering that blood pressure, your baroreceptors are going to then increase your sympathetic outflow. It's also going to act on your kidneys to increase your renin. You'll have sodium and water retention for those reasons. Increased blood catecholamines can cause hyperglycemia, and this is again because you have alpha agonist like inhibition of insulin release, and it can cause CHF in susceptible patients. Any questions on that? We don't give that a whole lot, but I think it's a good thing to understand. Another direct acting. The next class of medications we're going to talk about are the organic nitrates. And your main one is nitroglycerin, which I'm sure you guys have all given or will give soon. So the way that organic nitrates work, remember your direct nitric oxide vasodilators release nitric oxide. So this one is, these work through denitrogenation. The organic nitrates release nitric oxide. I'm pretty sure there's a picture on this. So nitroglycerin is your main one. Its predominant action is on your veins, so not so much on your arterial signals. Bless you. It causes an increase in your venous capacitance, decreases your cardiac preload because you're vasodilating your venous capacitance, and it reduces the cardiac oxygen demands. It also works on your large coronary, and it promotes flow through collateral circulation, and that's in contrast with nitric oxide. So this path, if you can see the difference between the sodium nitroprusside and your nitroglycerin. So this is actually donating this nitric oxide molecule, which is going to act on to increase your cyclic GMP. Your organic nitrate is going to be denitrogenated. So there's, it's going to kind of transform in the presence of this S-nitrous thiazole, and it needs another thiosulfate compound to work with. And together that's going to form nitric oxide. So this just gives off the nitric oxide. This one has to react with something to form nitric oxide to do the same thing. This works more on veins than it does arteries. Remember, nitric oxide is on both.
This picture is a bit cut off on
Is it cut off on your guys' too? I'm sorry. Can you move it?
Oh, no.
I think I might have done yours as a PDF. Okay. Sorry, put that one for you guys.
If you go to Chrome, you can extend it to the
Okay. So the use of that.
So you don't have coronary steel with the with this one?
You don't.
Okay.
No, you don't. And this works on larger coronaries. So I think the problem with the other one is that it's not acting so much on your large coronaries. It will act on your, like the little arteries, right? So if you think of a coronary has branches, right? And so if nitride is acting on the non-sick little branches versus the sick branches, it's going to pull things away. Whereas this, it's not acting on the little baby ones. It's acting on the big coronaries. So it's going to cause vasodilation. So it's going to increase blood flow throughout. So everything that's different. Does that make any sense?
Yeah.
So, and that's why it doesn't cause that coronary steal like the nitride does. So you're increasing kind of on the same percentage. Like if you're increasing blood flow through the large coronary 25%, the blood flow to all the smaller ones, including the sick one, is also going to increase by 25%. So it's not going to pull things away because it's acting on the small ones. Yes.
And what I'm thinking about is like if you, I mean, these are not like the first line blood. So this is if you have a hypertensive emergency, right?
Yes.
So
yes.
How do you even, if you don't know what your afterload is, your preload, how do you decide, well, am I going to give nitroprusside or nitroglycerin?
That's a good question.
If they're having chest pain, you give nitro, and then if they're a hypertensive emergency, then you give nitride. You know, and then you keep giving nitro until they don't have chest pain.
Nitride if you don't know.
Yeah.
You're going to reduce everything. Okay.
But then
obviously,
check a lactic.
If you're seeing ST elevation in their hypertensive, you're probably not going to choose nitride because you don't want to steal away from those things. You would probably give nitroglycerin first.
Okay.
And that's one of those funny things where it's so, and that's what anesthesia is. It's so patient specific and case specific and all these things. Just kind of knowing that and you'll get a little more familiar with it the more we go. But I think that's a good way. Hypertensive crisis or things like where you're trying to increase blood flow to the brain, not to increase our ICP.
Yeah.
You would use nitride. Things that are with the heart, or you have all of the cardiac monitors, so you know things like your preload, you know that you have a CVP, things like that, then you could talk about giving nitroglycerin. The only time I think I've ever given nitroglycerin was in heart rooms. That was a long time, other than, giving for somebody who's having ischemia.
Well, and in practice too, nitro, people become resistant to nitro really quickly.
Do they?
Yeah, like, I mean, just as my background as a cardiac nurse, like, I mean, you just end up going up and up and up, and you're like, this isn't working, and we need to get nitride.
We need to do, so then you go to that.
Yeah.
Should be the other way around. Just start with
Either
nitride.
you say-
Well, it's just like when you're working with hearts, everybody thinks, oh man, you need nitro, you need nitro.
Anti-angina, pulmonary edema and CHF, sphincter OD spasm, that's another good one to know. Have you ever heard of that? Have you ever heard of
Morphine.
So people will have horrible pain, and they can have chest pain, and it could be a flare-up of their of their bile duct. And so things like giving them morphine, giving them fentanyl can actually cause spasm of your sphincter oddi. So the thing where you can kind of tell whether it's cardiac versus a sphincter oddi spasm, nitroglycerin would actually fix both. So that would be kind of your go-to. Like giving them a narcotic, if you're worried about that, actually can make it worse. And then uterine relaxation, which we don't use a whole lot. Okay, so with nitroglycerin, because it acts on your venous capacitant vessels, you have decreased venous return and decreased cardiac output. It doesn't have any direct inotropic action, so it's not really acting to increase their heart rate or anything like that. It decreases their central blood pressure because you're decreasing your cardiac output. So it may evoke a baroreceptor response, but not as much as with nitric oxide or nitrite. So that can indirectly increase the heart rate and contractility, but not as much. Your SVR is unchanged, your PVR is decreased, and you have decreases in your myocardial oxygen consumption. In this textbook, they may develop a tolerance, but I guess clinically you probably see that a lot more than others. So some of the adverse effects, they can have tachycardia, they can have palpitations, hypertension. Not as much tachycardia as I would suspect with the nitric oxide. They can have headache, dizziness, vertigo, flushing, nausea, vomiting, methemoglobinemia, and that's especially in patients with hepatic dysfunction. The treatment of methemoglobinemia, do you know that? It's methylene blue, either 1 to 2 milligrams per kilo over 5 minutes. It can decrease your sensitivity to heparin by decreasing its binding to antihypertensive 3, and so you might require an increased heparin dose to meet that endpoint. So pharmacokinetics, the onset is immediate, duration is not long, protein binding 60%. And again, I'm not going to test you on things like 60% protein binding. I think it's good to know the ones that are highly protein bound, because that's good for practice to know that if somebody has any issues with their protein, they would have more drug available. Half-life is 1 to 4 minutes. Elimination is excretion of inactive metabolites in the urine. Any questions on organic nitrates? All right, now we have your vasodilators that are your potassium channel activators. This is your hydralazine, your minoxidil, and these activate potassium channels. And so what happens is they increase the potassium conductance across the smooth muscle, which hyperpolarizes the cell membrane and inhibits calcium influx. So if you don't have calcium going in, the calcium can't bind to cause muscle contraction. So it causes relaxation of the vascular smooth muscle. But these are just pictures, just to show you kind of where all of these drugs can act to do the same things in different ways. Okay, so these are going to stop your potassium channel. So it's going to hyperpolarize the membrane, and therefore your calcium is not going to go in, so it's not going to act on your muscles in your veins. So, and that's going to cause vasodilation. Hydralazine is something you will use a lot and you'll see a lot. It's a direct acting vasodilator by the potassium channel activation. It lowers your blood pressure by direct relaxation of your smooth muscle, because again it activates that potassium channel, hyperpolarizes the membrane, which decreases your calcium from going in, so it causes vasodilation. This is an arterial vasodilator, so nitroprusside is both, nitroglycerin is in the veins, and then hydralazine is an arterial vasodilator. It does not dilate your capacitant vessels, so not your venules. It does not relax your venous smooth muscles, which is why it doesn't dilate your capacitant vessels. and it has a reflex stimulant of your sympathetic nervous system. So you will see an increase in your heart rate and contractility, increase of your renin activity, and fluid retention. Under anesthesia, this is something that you kind of consider like, okay, this patient is hypertensive. What do you get? Well, then you look at your heart rate because you know that with hydralazine, you're going to see an increase in heart rate. So in somebody who's, older, that you don't want to, who has coronary disease, you don't really want them to get tachycardic, hydralazine probably wouldn't be your antihypertensive of choice. You'd probably want to go with something that would cause a decrease in their blood pressure. But in somebody who has, a blood pressure of 180 over 100 and their heart rate 60, hydralazine is a really good choice because not only is it going to lower it, it'll only increase it to about maybe 80 at the most. It doesn't increase it. You don't have like a really reflex tachycardia. You do have some tachycardia. So that would be safe. Does that make sense? And you guys will get feel that the more you're in clinic. So uses, hypertension, we see this all of the time in patients with preeclampsia. Did you guys have obstetrics yet? So you don't know anything about that. And then chronic heart failure. So adverse effects will have some reflex tachycardia. That's why it's important before you give hydralazine to look at what their heart rate is. So if it's already 100, you're not going to choose this. You can have some sodium and water retention. Why? Because it's going to activate that Renin-Angiotensin System. You can have prolonged effects in patients with renal failure. You can have some aplastic anemia, and then lupus-like conditions. And that's usually with higher doses, like a drug fever, the butterfly skin rash, and pancytopenia. Onset. This one takes a little bit longer, and this is something that is important when you're giving anesthesia, because the more you guys are in clinical, the more you're gonna, we are not patient people at all. Like, you want something, you want it now. You want the patient asleep, you want them asleep now. You want them to wake up, you want them to wake up now. You want their blood pressure lowered, you want it lowered now. I mean, we are not patient at all. This is one that you can kind of get into trouble, because if you have somebody who's hypertensive that you choose hydralazine as the best choice of drug for them, and you give it, you have to realize that it can be 15 to 20 minutes before you get your onset and peak effects. So you can get you give them, we usually give 5 milligrams at a time. It comes in a vial of 20 milligrams per ml, so you always dilate hydralazine. And you give them 4 to 5 milligrams at a time. And if you give them too much, and all of a sudden this kicks in, 15 to 20 minutes later, then they're done. Then they're really hypotensive, and now you're combating all of it. So you just want to keep that in the back of your mind, that your onset is a little bit longer compared to most drugs that we give under anesthesia. Yes.
So it's 15, onset not 5.
I mean, you can see some in 5. Typically, it says 5 to 20 minutes per book, and that's just because everybody's different. So the time that it takes to, stimulate the potassium receptor, it's just different in everybody. But just keep that in the back of the mind. You want to be patient. I don't care. It's not going to be you're not going to be tested on numbers like that. It's just a little bit longer than most of the drugs that we give in anesthesia. Duration, it lasts a long time too. So that's another thing to be cognizant about when you're giving anesthesia, because are they hypertensive just because, it's a very stimulating part of the surgery and they're not really a hypertensive patient? Because then you're giving them a vasodilating drug that's going to act for 3 to 8 hours after. And you can have some marked hypotension post-operatively in people like that. So you just kind of have to think about their history, what's going on with the surgery, what their heart rate is. And that's not something that you guys are expected to know now, because that takes experience and time. The distribution, it does cross the placenta, so not that that would matter to you. Right now, metabolism, it's metabolized by acetylation in your liver. Protein binding, it is very highly protein bound. The half-life is, like we said, 2 to 8 hours. In end-stage renal disease, it can be 7 to 16 hours, so it can be a lot longer. And only 14% is excreted unchanged in the liver. Any questions on our vasodilators? All right, so calcium channel blockade. You get Dr. Schwartz for that. So we don't have to even touch on that, but just to kind of backtrack to what we started talking about, and these are antihypertensive agents. So that's just one of the classifications that is used for the treatment hypertension. All right, next we're going to talk about reduction in angiotensin concentration. And these are by your ACE inhibitors and your angiotensin receptor antagonists. All right, so we know that angiotensin 2, and I'm sorry for being so redundant, it's just important, and I think it helps to keep going. So angiotensin 2 normally binds to specific cell membranes that ultimately leads to increase of calcium from the sarcoplasmic reticulum to produce vasoconstriction. Angiotensin converting enzyme inhibitors block the conversion of angiotensin 1 to angiotensin 2, and that happens in your lungs, right? So ACE inhibitors work, and this results in a decrease in angiotensin 2 and aldosterone, because if you remember, aldosterone is excreted in response to angiotensin 2. So if you don't have angiotensin 2, then you're not going to have the aldosterone. And it can also increase the endogenous vasodilators like bradykinases, and those vasodilation. These are safe for diabetics. Some side effects that you would see with some of the other antihypertensives you don't see with ACE inhibitors. Things like heart failure, bronchospasm, bradycardia, and exacerbation of peripheral vascular disease. So that's why it's kind of considered one of the safer medications, and you'll see a lot of patients on it. So basically, what happens when you give ACE inhibitors, you have your, so the main effect that what we really look at is the conversion of angiotensin 1 to angiotensin 2. So it blocks that. So if you don't have angiotensin 2, you don't have direct vasoconstriction, so you have vasodilation, and you don't have the increased secretion of aldosterone, so you don't have this blood pressure increase. So you're blocking this here. It's also what happens is ACE inhibitors block the activation of this kinase 2. So you don't have accumulation of bradykinin, sorry, that's different than what my understanding was.
Isn't the bradykinin what causes the cough?
I think it is.
You know what I mean?
Yes.
Yeah.
So let me look at this and clarify this a little more, because I thought it blocked the activation of the bradykinin.
Yeah, I don't know.
Just from my previous studies I've written down.
Yeah.
ACE functions in deactivating bradykinin, which is a vasodilator.
Yes.
So if we're blocking the ACE, then it's not going to deactivate bradykinin.
Yes. Thank you.
Okay.
Right?
That makes sense. I'm like getting the ACE, because we're blocking that. Yes.
So you're blocking the breakdown of the bradykinin? Okay. Yeah.
Yes.
Okay.
ACE inhibitors, one of the big things would be the cough, and that's because of the bradykinin.
Okay. Perfect. Thank you.
You are very welcome. I'm sorry.
No.
Okay. So it's popular, we already said, because of the decreased adverse effects. It's usually a first-line therapy now. Thiazides used to be the first-line therapy for reducing blood volume. Now it's kind of falling more in the favor of these inhibitors, and for people with systemic hypertension, CHF, and mitral regurg. These include lisinopril, captopril, and alpril, any of the prils. Side effect, the cough, like we said, upper respiratory congestion, rhinorrhea, and allergic-like symptoms. Life-threatening angioedema, which is probably why I'm so tired today, because I had one of those last night. When we're in OB, we get called to the ER for airway emergency, and this is like a real thing. So So anytime anybody says anything about having angioedema, you just hear it as being very scary because their airways get really bad very quickly. I went down to see this woman, and this is the interesting thing about her is this is the third time she's had angioedema. She's been on her ACE inhibitors for 3 years after the first bout of it. And I went to see her, her lips, no joke, were empty here. Her eye was all swollen shut. Thankfully, she had good mouth opening, but you could see the back of her soft palate was starting to get swollen. And so you do things like you give steroids, you give antihistamines, so you give Benadryl, you also give Pepsid, like histamine 1, histamine 2 blockers. And now one of the newer treatments is FFP. And it wasn't getting better, so we decided to take her to the operating room to intubate her, which is sad because she's a young woman, but it's life and death and it's better. The other thing is once this starts swelling on the edema in their smooth muscle, it can distort your trachea. So if it gets to a life-threatening situation, then you need to treat them because there have been times where you really can't. It's hard to even get a trachea. So it's just something that I always think of. Another story about this because I feel like I've been getting a lot of experience with angioedema. We had a patient at the surgery center that came in for a cataract, and thankfully, he almost looked like he had collagen, like injected in his lips, and we wouldn't have known because he just had like these puffy lips. And thankfully, the surgeon came out to see him, and he was like, "What's going on here?" And he's like, "I don't know. It just started yesterday, and his lips were getting swollen, and he was on an ACE inhibitor." So they were talking like, we're canceling the surgery and he needs to go to the he needs to go to the emergency room at a hospital, not a surgery center, and get this treated. So it's a real thing, and it can happen even years after people being on ACE inhibitors, and it can happen very suddenly and progress very rapidly. So you will probably come across this sometime in your career. Another side effect of your ACE inhibitors, it can decrease your GFR and cause, so this is using caution with people with renal dysfunction. I do not know, I will find out if they don't prescribe it so much in people with renal failure. I wonder if they probably would opt out not to, but it can cause hyperkalemia, and this is secondary to decreased aldosterone production. It can cause prolonged hypotension with general anesthesia, and this is what we said before. So this is the one medication that I kind of questioned whether you maintain it preoperatively for patients who are having general anesthesia. And these are also patients that if you give them general anesthesia and you have, prolonged hypotension that's not really reacting to your phenylephrine, ephedrine, the things that you normally give, you think of, okay, it's probably because they're on an ACE inhibitor. Volume helps. If volume does not help, then we usually go to vasopressin. And yes.
I'm sorry, this is kind of going back to what you said before. What's the mechanism that makes it so people still have angioedema after years of being on it?
That is unknown. They're still trying to figure that out. So they have no idea why it.
There's also hereditary angioedema. Last year when I was traveling, I saw a guy that had to get tubed because he just had hereditary angioedema.
Spontaneous.
Yeah, they think like autoimmune. Just something triggered it.
It's called a cyclooxygenase deficiency.
Yeah.
That's one that's a big one now. I just learned about this last night.
Oh, that's interesting.
So usually people who are prone to this and have the cyclooxygenase deficiency, it's usually found in childhood. But now they're finding that there are some adults that have it, that it just kind of spontaneously comes up. And that's why they're treating it with FFP, because FFP has cyclooxygenase, I guess. And so they'll treat it with FFP. Some hospitals actually have just the drugs, so they try that first. The problem, what we came into last night was, okay, do you really want to wait and see if it's going to get worse while you wait for pharmacy to get the drug, or do you want to get the airway secured, keep them sedated, give this medication, and then see if it gets better and then on the next day? And that's what we opted to do. Just kind of sad because she so,
She don't want to be intubated? I mean,
so she didn't not consent. Like, we took her emergently to the operating room.
and
Just to
why did you take her to the op, just because you could have to trigger?
Yes, yes. So we had the general surgeon in the room with everything set up for a trach. And we had bronchoscope, and we did everything to do no. We gave no sedation. And I know that that's why she didn't want it, because she had it in the past, was intubated for a week, and then I'm sure it's not a very pleasant experience. The problem is what you do. You know, do you wait until it gets so bad and then she could potentially die, and you have a 45-year-old woman who is otherwise healthy? So we just kind of, she consented to come up to the operating room. She didn't really want to get well routine, but thankfully she did okay.
Can you give any type of,
So the thing about it is that in somebody that you're worried about a compromised airway, for whatever reason, not even angioedema, anything that you're kind of, people compensate, and people compensate really well. And they're like on that boat, and any little thing that you give can trigger it, and it can make it really bad, and they won't be able to compensate. So anything, even like Versed or something that typically doesn't have any effect on breathing, can kind of tip the boat and make it so they are unable to compensate. So we gave nothing. We gave lidocaine. You know, I mean, you obviously can localize as much as you want. So we gave lidocaine. And then the minute that tube was in and we had positive CO2, we pushed propofol, put her on a propofol infusion. So hopefully her experience with it was maybe that was really bad 30 seconds. So
Do the same thing to me.
any other questions?
I'm surprised that we still use ACL. I mean, is it not common enough for people to?
It's not that
It's
common.
not that common. But when you see it, you feel like, why are we doing it?
Yeah.
Exactly. But the amount of people, I feel like too many people are on ACE inhibitors.
Well, the outcomes are so good for like hypertension and heart failure, because I mean, you get a decrease in preload and afterload, like,
Really relaxes the heart.
yeah. I mean, it really is like there's a ton of evidence.
And you saw those pathways where on all those different levels that it can evoke vasodilation and decrease blood pressure. So it works in a multitude of ways. So I think that's probably why it's still in favor. All right, so the other way we reduce angiotensin concentration is by angiotensin receptor inhibitors, which are your ARBs. Like, they block the vasoconstrictive actions of angiotensin 2. They do not affect ACE activity. So they just act on the receptor and antagonize it. So you still have angiotensin circulating around, but they can't act on the receptor to elicit a response. This is losartan, any of your sartans. They block the vasoconstriction actions of angiotensin 2, and they don't cause a cough, which is good. Well, they cause a cough far less than patients with ACE inhibitors. And that cough can be really, really annoying to some, to the point that they don't want to take their medication. So this would be a good kind of second thought for them. It can cause hyperkalemia. And this is another one of my pictures just to show you kind of where it's acting. So it's blocking the effects of the angiotensin 2, which would cause vasodilation. Any questions on this? We don't give them a whole lot as far as in anesthesia. That's why we don't go into all that pharmacokinetics. The other drug therapies for treating hypertension are ganglionic blockades. And this would be your trimethophan. And this causes a competitive antagonist of acetylcholine at your postsynaptic nicotinic receptors in your autonomic ganglia. And this would block your sympathetic nervous system and your parasympathetic nervous system. This will make a lot more sense after our next lecture when we talk about the physiology of like what preganglionic, postganglionic, nicotinic, muscarinic receptors. This would make a lot more sense. So, but basically it blocks acetylcholine in your sympathetic nervous system. So basically what happens, to kind of give you a precursor to it, when your sympathetic nervous system is excited, it releases you have two synapses. You have one that kind of goes to the cell body and it synapses with a postganglionic nerve that goes out to the receptor or the end organ and elicits a response. So where the synapse is outside of your central nervous system in these cell bodies, it will block the synapse with the second nerve that will go to the end effector organism. So it's kind of blocked there, so you're not having the response elicit at that end organs. Does that make any sense? And you'll see lots of pictures of this in the future. So this decreases your preload and afterload, and it promotes venous cooling. It lowers your blood pressure by direct smooth muscle relaxation, and that's really because you're not getting that sympathetic stimulation to your blood vessels. So if you're not getting that sympathetic stimulation to constrict them, they're going to vasodilate. And that's what will decrease your preload and your afterload, because it's going to act on both your veins and your arteries. It can also have the smooth muscle relaxation by histamine release. So people who are more prone to having like asthma, things where histamine would be a problem for them, this probably wouldn't be a good medication for them. It's metabolized by plasmacholinesterase, and it does not affect the central nervous system because it's charged, so it doesn't cross the blood-brain barrier. It has a rapid onset, short duration of action. Side effects, it can cause a potentiation of neuromuscular blockade. This is just something, anytime you hear of this potentiation of neuromuscular blockade, the important thing for being an anesthesia provider is thinking like, okay, if this can potentiate the block, you might have a longer response from giving somebody like rocuronium, pecuronium, any of your neuromuscular blocking agents. They might have a longer response from it. So you might get away with giving a little less for them. Or you just might expect that. The nice thing is, you guys have been in clinical that much, you have Cigamidx now, so it kind of doesn't really matter. But back in the day when we didn't have it, this was something they kind of wanted to be cognizant about. It can have significant histamine release, like we said. This can cause tachycardia. It can also cause bronchospasm, especially in patients who are like chronic asthma. You can get orthostatic hypotension, pupillary dilation, cycloplegia, tachyphylaxis, constipation, and urinary retention. So the uses of it are limited, secondary to multiple side effects. So it's not used very much, but it can be used in a hypertensive crisis. It can be used in a dissecting aortic aneurysm, pulmonary edema, and to decrease blood pressure in neurosurgery. I have never given it, but I'm sure there are many questions. Any questions? All right, and then the last therapy for hypertension is the inhibition of neurotransmitter release. And these are drugs affecting neurotransmitter release or reuptake, like Vasodilators or Renin-Angiotensin. And I have not given many of these, but I think they're good to know because you have to think of how this will affect other things in anesthesia. We'll talk about it. So basically, add to your motor end plate for your sympathetic nervous system. And we'll talk, this will make a lot more sense after our next lecture. So you have sympathetic nervous system stimulation. It's going to leave your brain and your spinal cord, and it's going to synapse. Remember we said the preganglionic nerve, it's going to synapse with the postganglionic nerve. The preganglionic nerve releases acetylcholine. Acetylcholine is going to act on the receptor on the postganglionic nerve. That acting on it is going to elicit the action potential to be propagated. At the end of that nerve, at the end of your postganglionic nerve, it releases norepinephrine. So norepinephrine is going to act on those things in your sympathetic nervous system that are going to elicit the response. Norepinephrine is going to act on your blood vessels to cause vasoconstriction. So if you're blocking the effects of norepinephrine release or the reuptake of it so that it's not there to be released, then it's going to block those vasoconstrictive effects. Does that make sense? And you don't get